Welcome. Today I am at a slightly noisy place. Am I audible to you? Can you listen to me?
Yes, yes, sir. Yes, sir.
Yes, actually, yesterday there was some problem in my laptop, so I couldn't conduct the class in a proper way. Okay, today I will just try to get it. So we will just quickly revise the topic which we discussed yesterday because the recording was not done. Okay, so some of the people may be new. So first of all, we will just have a look on what are the ways to assess the severity of bleeding. Can anyone tell how to assess the severity of bleeding intraoperatively? Can anyone comment something? Yes, Shamail or Dr. Azam, who wants to speak out?
20%.
Just a second, please. Mute yourself again. Unmute yourself, please.
Sir, in other case, 20% blood loss is there, then there's a trigger point.
No, I repeat, your voice is very slow. So if you can speak out a little loud.
Sir, in adults, as far as I remember, if the trigger point is like that, if 10 to 20% of the blood volume is lost, then it is a triggering
No,
point.
actually, I'm sorry. You need to speak directly, not through the speak like mobile. I think you are talking because your voice is not audible. My question is not this one actually. My question is that how to assess the severity of bleeding. Yes, can you speak out now?
Yes, sir, I'm saying the triggering point for the blood transfusion is that if,
No,
yes.
Azam bhai, I will rephrase my question. Like for example, your answer is correct for some other question. I'm asking that how will you assess the severity of bleeding? That how will you come to know that 10% or 20% loss has been occurred? This is my question.
Yes, sir. I mean, this is the extent of loss, and it will be represented by the sign and symptoms of the patient intraoperatively.
No, I'm sorry. We are not. I cannot hear you. Actually, the first sign which you can see is the direct visualization of the surgical field. It will give you some information. Then the surgical gauze. Okay. Then the suction bottle. Okay. And simultaneously you will be looking at the vital signs. Okay. Usually whenever there is a hypovolemia, the sympathetic system is activated and there is reciprocal tachycardia, except this will not be accurate if you are having a patient with some physiological change, or some patient is taking some medication. Okay, or in patient has some pathology. So in that case, maybe the sympathetic response is not that much and you are not able to identify. Okay, so initially there will be some changes, blood pressure or heart rate. Am I right?
Right.
Okay, so other signs will be like peripheries may be cold, there will be mucous membranes will be dry. Okay, dry mucosa, dry tongue. Okay, so skin turgor will be decreased according to the level of hypovolemia or level of bleeding patient is suffering. Okay, and it will also differ in case of patient is whether his patient is under spinal anesthesia or general anesthesia. This will also be affecting some of the aspects. Okay, so then objectively, if for example you are monitoring the some invasive things, like for example there may be some changes in CVP. If the CVP is in place, there will be some changes in the form of, if the patient is having cardiac output monitoring or even intra-arterial blood pressure monitoring, that will be giving you some information. If the patient is hypovolemic, there will be some changes in the waveform. If the patient is hypovolemic, there will be some changes in the stroke volume variation. Stroke volume variation is a normal change which occurs during inspiration and expiration. If this change is increased, so that's showing that patient is hypovolemic. Okay, so this will also be giving you some idea. So like you will be assessing the surgical site, you will be assessing the blood coming on the for example on the floor, or in the gauze spaces and in the drains, like by the suction drain. So you will be, if for example sometimes there are some surgeries in which they are putting some saline. Okay, so for that purpose you have to be very accurate. You have to ask how much was the irrigation. So you will subtract the irrigation fluid being used. So in that way, then the next step will be that what stage of hypovolemia you have. Okay, so in that case you will be saying that patient is like 10% loss or 20% loss or 15% loss. Okay, so this is the concept which you should be knowing, and it is applicable to these points. You can apply on almost all of the patients. There will be a little bit difference in individual patients, like according to the age, like if just we correlate, if you have a patient younger age group, pediatric patient, the heart rate changes will not be that much reliable. Okay, because they already are having relatively higher heart rates, and the blood pressure and heart rate is not a very good sign in pediatric patients. Okay, and similarly, if some patients have some autonomic neuropathy, the result will not be accurate according to you. So you cannot rely only on the vital signs. Okay, so you have to correlate with the clinical features. Like in pediatric, you have to see the fontanelle, mucosa, and conscious level changes will be the next step. And then another thing which I missed is urine output, because as soon as patient is hypovolemic and hypotensive, the first thing to go is kidneys. So the urine output will be decreased. So it is one of the factor, in addition to the skin, mucosa, mucous membranes, okay, and other things. Okay, so this is the first part of our discussion. There, if anything, if anyone wants to add to what I have told, anyone, any more point related to this point, how to assess the severity of bleeding, or how to assess the severity of dehydration, or how to assess the severity of bleeding. Okay, hypovolemia. So these are the things, and then next step is that you quantify on these bases as 10%, or I will just show you the chart, which you should be knowing all the time. Just a second, I did not open it. Okay, so this chart you will find in different chart, different reading, but actually you should be knowing it, that usually in class 1 and class 2, if the initial hemoglobin was in the lower in the normal, so patient in 1-2 can tolerate without blood, and 3-4 definitely needs blood. Okay, usually this is the rule. But for example, if the patient hemoglobin was already low and the allowable blood loss was very low, like patient hemoglobin is already 10, for example, and you have a cardiac patient, so practically speaking you have to replace blood with blood. So transfusion triggers is a little bit different thing to be considered. In a normal individual, maybe patient may tolerate 6 to 7, for example, but in patient with some comorbidity, especially the cardiac comorbidity, they need higher hemoglobin to have the oxygen transport properly. So you should be knowing this chart at your tips. You should have no doubt about this chart. There will be changes in heart rate, blood pressure, respiratory rate. Basically these are normal things. And one thing they have not written here is the conscious level, because conscious level change will also be, in this one they have written. Okay, So they, as soon as it is class 3 or 4, the patient will be a little. Okay, so these are the same thing which I was telling you: blood loss in ml, in percentages, heart rate, blood pressure, okay, and pulse pressure, respiratory rate, urine output, CNS, or and initial fluid replacement. Okay, so this is how to, because as the first thing for you to do is to assess the severity of bleeding. Okay, so this is common, and even if you have a pediatric patient, they will be more, the terminology being used is dehydration. You will be using this knowledge when you are managing a patient with infantile hypertrophic pyloric stenosis, or even tracheoesophageal fistula, or patient is having gastroenteritis. The main things are the same. Okay, but in pediatric patient, the clinical signs symptoms will be a little bit different. Just to additionally, I told you. Okay, so the second part of our discussion is this blood conservative strategies. Okay, blood conservative strategies we actually discussed yesterday. It will be a little bit revision sort of thing, that what are the different ways. Shemail, now you can, because you were here yesterday, so if you want to speak out, please. What I told you yesterday, you can just speak out. What are different ways to avoid the I'm sorry. Actually, the concept of this topic is, yes, Dr. Rai, you want to say something?
Yeah, I just wanted to ask regarding this. You said higher transfusion trigger for IHD patients or patients with other comorbidities. What is the general trigger? Is there a written trigger that they usually follow?
Yes, you have a very valid question. Actually, the thing is that these whatever guidelines they create, this is just to help you out. Actual transfusion trigger is according to the patient. Okay. For example, if the patient is already have 7 hemoglobin and the patient is ongoing bleeding, maybe you will start transfusing even at 8, for example, because you will not let the hemoglobin to fall below 7 or 6. Am I right? Similarly, in that case, if there is any option of controlling the bleeding, so you can hold on, attach the blood, and you can just wait for few minutes according to the scenarios, according to the situation. That, for example, if you are giving the blood and you have 4 units of blood, okay, and if patient is still bleeding and you give it, maybe there is a chance that blood is already lost. So that time you can get in 15-20 minutes, half an hour time, you can get it by giving some colloids and crystalloids at that time, and you will keep the blood with you hanging until the time they have secured the blood, the bleeding source. Okay, so this is practically, if you are in an oral examination, I think that if you answer in that way, the examiner will knowing that you know the exactly what you have to do. Okay, so these transfusion triggers, the lower limit is that one. Ischemic heart disease, because they have the limited cardiac reserve, and they are prone to get ischemic. So if you decrease the hemoglobin level, the oxygen content will decrease significantly, and if they have some coronary artery disease with decreased delivery already, so they cannot compensate for it. Okay, usually in other young patient, maybe they are able to tolerate it by the compensatory mechanisms which are there, by increasing the heart rate, increasing the blood pressure, this one vasoconstriction, and the local metabolic pathways for which is there. Okay, but in ischemic heart disease patient, if there is significant blood loss, they will not be able to tolerate, because they are already ischemic. Okay, that's what my point is. Am I right? Am I clear?
Oh, yes. Thank you. Another question.
Yes.
How you said 10%, 20%? No, is that of the blood volume?
It is, yes. It is the blood volume.
Or the plasma volume.
Yes, it's how you calculate the blood volume. Okay.
Yes.
So this is total blood volume.
Into the plasma volume.
Plasma volume. Let me explain to you, or let me clear myself as well, that what does it mean. Usually, how we calculate the blood volume. When we calculate the blood volume, we are calculating the whole blood volume. Am I right? So
Yes.
that is
Yes.
around in adults in 60 to 70, for example,
5
you take it
liters.
70 for example. So to be round off, you in 70 kg it is roughly 5 liter. Am I right? So we are
Yes.
calculating from that one, and these numbers
Yes.
actually, what more important is percentage rather than the actual volume. Okay, because maybe patient is having higher blood this higher weight, but actually we usually, I think, if I'm not wrong, because this is a very valid question, that we have to calculate with the total body weight, or we have to calculate like we usually do in all patients, we calculate according to lean body weight. So in that case, female will not maximum, we will calculate from 70 kg, and we are considering maximum a man as 100 kg. Okay, so this is, I think I need to confirm it. If you want to clarify, you also should search that how we calculate the which weight we use for calculation of blood volume. I cannot recall at the moment. Okay, so that will be important thing
Okay.
too, because initially you will calculate the blood volume, then you will calculate the allowable initial hemoglobin, and then you will calculate the allowable hemoglobin. Like for example, the hemoglobin was 13 or 15 for example, and you can allow up to 10. So that will be allowable blood loss roughly. So if, for example, to make simple, 5 is the difference. So some people divide it by the initial, some people divide it by the average. There are slightly different in different books, you will find different, like the difference 15 minus 10 is 5. So over divided by it, some people take it the initial hemoglobin, some people take it final, some people take average. Like in average, you will be dividing it by 12.5 in that scenario. Okay, so the number will be a little bit different, but to be very simple, it is usually initial hemoglobin, you use it. So difference divided by initial hemoglobin. So 5 by 15 example, multiply by blood volume. So I'm just making it simple because I don't have still it at the moment. I would maybe have explained to you in a better way. I mean, so 5 by 15 multiply by 5000. Okay, so that will be the answer for your allowable blood loss. Okay, okay, so it will be around 1500 ml in that patient. If the hemoglobin was 15 and you can allow up to 10, so the difference is 5. So 5 by 15 multiplied by 5000, it will be around, to be very specific, 5000 divided by 3, around 1600 something. Okay, so that is the concept of allowable blood loss. Okay,
Thank you. Thank you. Thank you.
I hope you are clear. Okay, okay. So the next part is that how we can avoid the homologous blood transfusion. Okay, so actually this topic yesterday we discussed. So there are different maneuvers to handle it. Let me try to find out the still it. Just give me a second, please. Okay, so am I visible to you? Yes. Actually, the first part we have covered is assessment. Okay. So the other part is that how to first of all avoid blood transfusion, and how to avoid blood from other person that is homologous. Okay. So go for autologous. Okay. So our discussion will be hanging towards this thing, that how this will be assessment will be in emergency as well as initially. Okay, so initially you can have the baseline anemia, you have to correct it by increasing the sources of making RBCs or hemoglobin. Okay, this is one thing, and other is to minimize the losses. Okay, minimize the losses you are having. So this is one aspect. You can advise some just a second. You can advise some anticoagulants. Okay, you can advise some anticoagulants. I'm sorry, I'm using the wrong word. You can stop anticoagulants, you can stop antiplatelets. If the patient is you can say you have to manage them. Okay, you can correct iron, you can correct vitamin B12, okay, folic acid, okay, and you can treat any cause, any obvious cause. This is a long topic, we will discuss later on sometime. Some of the aspects we have already covered in our preceding discussions of about anemia. So you will be correcting, minimizing, and then because our focus here is how to avoid the blood transfusion or something. So there is one way is blood conservation. Okay, blood conservation, that this theory is being used by patients having rare blood group. Okay, so what you can do that serially over this, of course this can only be done in this elective surgeries. Okay, so they can withdraw the blood, okay, and replace it with crystallite, okay, and then they can have these supplements so that the hemoglobin will build up and they have stored their own blood. So this is one of them, and according to the temperature they are storing, they can keep it according to that thing. So this is one way. Okay, other way which will be occurring, that you are now you have the patient on day of surgery, you can do that, you can withdraw the blood and replace it with the equal volume. This is called as normovolemic hemodilution, like you are diluting the blood. Okay, so one way is normovolemic hemodilution and the other way is hypervolemic. So the difference is that in normovolemic, you, for example, you replace you take 1 unit of blood and replace it 3 to 4 times of crystallite or equal volume of colloids. So what will happen, that you will withdraw it, keep it safe, and then you self transfusion, like you can say auto transfusion. Okay, so what will be the advantage, that you are giving the whole patient's blood to the same patient. Okay, and of course whatever technique you are using, you have to see at the situation. Not every technique can be used in every patient, mind it. Okay, but these are the things which you can do: normovolemic hemodilution, hypervolemic hemodilution. In hypervolemic, you don't withdraw the blood, you dilute the blood. Like for example, above the dehydration, you are giving, for example, 1 liter of fluid extra you are giving. So that one will be diluting the blood. So effective, what is the purpose? If someone asks you, effective RBC volume loss per ml is decreased. Okay, so that is the purpose, is that you are diluting it. Yesterday I gave the example that if you have a specific amount of in Saudi Arabia people are familiar of Vimto, and in Pakistan, India, there is a drink Ruh Afza or Jami Shiri, which is like sweet drink, and you have more people, like it is serving 100 people. Now you want to serve it to 200 people. What you do, you put more water. So if you put more water, the effective drink is diluted and more people can take it. So similar is the theory, that if the same 1 ml blood loss occurs, so for example, before it was 10 RBCs in 1 ml, now you dilute it, so in 1 ml now there will be 5 RBCs. So this is the concept of hemodilution. Okay, but what will be the limitation, that you cannot do it in the patients having limited cardiac reserve. Okay, limited cardiac reserve, you cannot do this thing. If you have ejection fraction, fixed ejection fraction or lower ejection fraction, patient cannot tolerate, so patient will go into overload. So the thing which will limit this technique will be volume overload. Otherwise you can use it. Then there are some techniques related to the basic anesthesia care. Okay, so you are maintaining the this is not hemostatics, this is homeostatic conditions. Okay, homeostatic conditions like oxygen, hypoxia, you will avoid hypoxia, you will avoid hypercarbia, you will maintain normal temperature, because if temperature is low, there is platelet dysfunction and there is more bleeding. Okay, then you are having, initially you correct the dehydration and you have normovolemia. Okay, then another thing is hypotension. It's controlled hypotension. Okay, this controlled hypotension is called as hypotensive anesthesia. Okay, so you have to rule out certain conditions in which you cannot give and this is that you take the baselines. Okay, and you have to maintain around 20 to 30% of baseline. You can reduce, for example, if the initial hemoglobin was around initial blood pressure was ranging of mean of 100, so you can come down to 70 or 80. Okay, actually you can come down to 60 as per the auto regulation of brain is 60 to 160 millimeter mercury, and for kidneys it is 80 to 180. Okay, so preferably actually you should not try to go sustained hypertension less than 80, because otherwise there will be some problem. If the patient is having some baseline renal problem, you should not get the blood pressure less than 80. Okay, but for brain it is around 60. But the better way to tell is that you will take the baseline and you will try it. And another thing is that, because you will find it in ENT, you will find it in spine surgery, you will find it in orthopedic surgery, a number of surgeries in which they want hypotension. Okay, so the things which can help you is, one of them is tourniquet. Okay, you can use tourniquet to reduce the bleeding. This is one thing. Then you can have a specific positional strategies, like you will avoid venous congestion. Okay, you will avoid venous congestion, so that, for example, if you have neurosurgery, it can be scars in neurosurgery as well. So if you have having, for example, ENT surgery going on, so if you are making head side a little higher up, there will be decreased venous pooling. Okay, so your hypotensive anesthesia will also be helping. Okay, in that case usually it is better to maintain to monitor intra-arterial blood pressure monitoring. In that case, if you have make the head side a little up, for example, you should level the transducer at the level of, not of heart, at the level of external auditory meatus. Okay, because it will give you a better idea of cerebral perfusion. Okay, cerebral perfusion, that is a theory. When you are making head side up, it is better to level intra-arterial blood pressure not at the level of heart, slightly higher, so that reading will be slightly reflecting the cerebral perfusion. Okay, so of course you will not do everything in every patient. Maybe young patient tolerate 60, no problem, nothing will happen. But if you have a diabetic patient, hypertensive patient, cerebral autoregulation shift is curved to the right, like not baseline is not the tolerable is not 60, maybe it is 80 or 70. So if you keep the patient in hypotension for longer time, there will be neurological injury. So that is the concept of understanding this controlled, sustained, allowable hypotension. And another thing is that you can slowly, gradually get your targets. If, for example, even the blood pressure was mean or around 100 and now you make it 80, and they are happy with the surgeons are happy with it, there is no problem. You don't need to bring it definitely at 60. So the concept is that you will tell them that the baseline is that, so the margin for me is only to go up till that blood pressure. So that is the theory to understand this controlled hypotension. Okay, so you make head side up, venous pooling, avoid venous pooling, you can use some tourniquet, and some other like thing which you are using intraoperatively. One of them is tranexamic acid. Okay, transamine, everyone knows about it. Mechanism of action of transamine is through plasmin, because there is one coagulation system in the body and there is opposite is fibrinolytic system. Okay, so if you want to to have your clot stronger, you will try to block it. So fibrinolytic system is through plasmin. So tranexamic acid actually inhibit plasmin. Okay, so what will happen, that there will be less fibrinolysis, so there will be microclot formation. But remember one thing, that there are certain problems which can occur. It is better to give infusion versus bolus. This is one thing, and there are risk of patient having some embolic phenomena, because it is one of the cause for transient blindness even. Okay, in a specific patient, especially if the patient is in prone position, you do hypotensive anesthesia, you give tranexamic acid. Now there is a chance of having ischemia of the eye, central retinal artery ischemia, because of hypotension, because of giving tranexamic acid. There are some microclots which were usually cleared by the fibrinolytic system. Now you have bribed and blocked that fibrinolytic system, so now there is a problem. So whenever you are doing something, you should be knowing what are the other part of the story. Okay, so these are the things which I just wanted to tell you. I will just show you what is written here, and then we will finish our discussion. Okay, so yes, actually one thing I need to tell, and then we will I can show you here. That is cell salvage. Cell salvage is a technique. You will see the picture over here. I will show you just a second. Cell salvage. So in this way, you are taking the blood from the patient, washing it, cleaning it, processing it, waste is discarded, and the same blood is being stored and delivered. Okay, so the theory is the cell save the cells. There are some problems associated with it, that if there is fecal matter in the surgical field or in obstetric patient, there are chances of amniotic fluid being transferred through this blood. And third thing is malignancy. Okay, so there is problem in malignancy, because malignancy can be transmitted. This is one thing. Obs patient with the amniotic fluid. Okay, and the third thing is fecal matter. So other limitation is that it only gives the RBCs. It does not give the clotting factors or platelets. Okay, so this is a limitation for it. There is system to concentrate, make it around, it is 70 to 80% hematocrit. You can decrease or increase accordingly. So this is another thing which they use. They are using it in any patient in which they are expecting more than 1 liter of blood loss, or 20% of estimated blood volume. Okay, so this is how they proceed, and some of the things I have already told you. Yes, one thing is, because this thing, if you recall, then you can use it in obstetric bleeding. That one thing is ligation of arteries, any vessel, ligation of vessels. Another thing is embolization of feeding vessel, okay, and this is being used in case of placenta previa accreta, okay, in which they go to interventional radiology and they embolize the artery. Okay, so this is, they are doing it. So this is another thing which can be said in blood conservative strategies. Okay, oh, I'm sorry. Yes, I'm sorry. Okay, so this is another thing which you should be knowing. Operatic, yes, and another thing is that whatever surgical technique or anesthetic technique you are choosing, you will be trying to have minimum invasive technique. You will be giving multimodal analgesia, because when multimodal analgesia you are giving, there will be reduced stress response, and then there will be less chances of bleeding. Okay, so regional anesthesia is one of them. Temperature regulation I told you, and stopping these medications, aspirin, clopidogrel, and everything. Okay, intraoperatively multidisciplinary team approach, and you are anticipating and managing. Okay, so the topic is very important, and if anything you need to be clear, you can just ask any question. Any questions, please? Dr. Roy, is it okay? Did I miss anything? Azam bhai, you want to ask anything? Okay, so domain. Okay, so domain of I think I was disconnected. The domain of this topic is very big. Okay, so I will just recap quickly. We started from the evaluation, how we can assess the level of bleeding, level of hemorrhage, and then how to avoid it. And actually, because in Jehovah's Witness usually this problem can occur, that they are refusing the blood transfusions. Okay, so their concept is that they don't allow, if the blood is taken away, discontinued from their body, they want it to be back. So these are the things. Yes, another thing is which I forgot to tell is, actually I don't have much of the concept. It's not, I have never seen, I think maybe it is theoretical thing. There is something, just a second, which is called as perfluorocarbon. Just a second. Okay, so it is called as perfluorocarbon. Okay, this is artificial oxygen carrier. I don't know much about it. Just in case in MCQs they ask, or if you have, I don't have much information about it, but I have read in it. There is some artificial oxygen carriers. Okay, so I think that's all about this topic. So inshallah we will meet again. Okay, thank you. Any questions before we finish? Okay, thank you. Bye bye.